Thank you very much. I'm going to start with the world stage, and on the world stage, miniature bypass remains a niche market, estimated at about 4 to 10%, which includes both the homemade circuits as well as the commercially available sets. Now, the reason I've got this guy balancing in the background is because miniature technology is certainly a balancing act, both in the selection of the technology and in the management of that technology. When we move to the literature, I suppose the early papers were examples of workers getting the balance wrong. 2005, Nollaret and his group identified the risk of air embolism with the technique and the loss of safety margins. And that was principally because that team had got the balance wrong in terms of the technology. In 2008, the T group out of Singapore identified amongst many positive benefits of miniature systems the fact that there was a limitation in the ability to achieve target cardiac index. Again, because of the closed system, this is possible, but for that group, it was an example of them getting the balance wrong in terms of the management of the technology. Probably the best paper to date, and did most of my legwork for me, thanks to them. It came out in April this year in Hart, out of Finland. And they pulled 33 comparative studies from the literature comparing miniature and conventional. They excluded 7 due to non-randomization, 4 retrospective, 3 duplicate data, and 6 with not enough outcome data. And they ended up doing a meta-analysis of 13 prospective randomized trials encompassing 562 patients. Now, their discussion mainly focused on the observational benefits, and I think these are the benefits that all experienced mini-bypass users observe. There was a certain decreased risk of post-operative stroke, observed better cerebral oxygenation, total embolic count, lower post-operative mortality, and perceived benefits in terms of post-operative bleeding and the use of blood products. All relatively soft conclusions. The overall conclusion of the group was the fact that miniature bypass in low-risk patients undergoing first-time CABG or AVR is associated with a somewhat improved outcome. Again, a relatively soft conclusion. They did make two other points that were very valid, and certainly something that our team feels are very, very pertinent to this technology. The first one was the fact that we need larger trials involving high-risk patients. And the second one was the fact that we require more homogeneous methods in this area of technology. Considering the researchers talked about more homogeneous methods, of the 13 papers in their meta-analysis, 54% of those studies included a system from the same manufacturer, which just highlights the fact there's so much user variation in the management of miniature technology, and it's far greater than the user variation that exists with conventional bypass. In terms of trials involving high-risk patients, and I suppose this was something that was touched on in the first presentation, the 562 patients, 88% were first-time CABG patients, 12% first-time AVR. And this is a patient population within cardiac surgery that we already manage very, very well. In Great Britain and Ireland, the 4-year mortality for CABG is 1.1%, and for AVR, 1.9%. So within this patient population, it's going to be difficult to move from observational benefits to statistically significant benefits. And we need to take the technology and focus the research and the clinical applicability on the 41.7% of operations that fall outside the patient population currently described within the miniature bypass literature. And again, that's a figure from Great Britain and Ireland for 2008. So with all that on board, we need to really go back to basics. Miniature bypass is a term that's overused and misunderstood, even in perfusion circles. It's not just about reducing hemodilution. There are lots of other benefits. And if we're going to get to those benefits, we need to understand conventional artificial heart and lung support, understand all the benefits of miniature bypass, as well as which benefits are the most important for our own hospital, and use all that information to accurately define the technology within the literature. Now, these are the systems that are commercially available. They're all grouped under the same umbrella of miniature bypass systems, and they have some generic attributes. They're closed non-compliant circuits. They control volume removal from the heart. they have a centrifugal pump, and pretty much they've got tip-to-tip biocompatible coatings. But these systems that you see here are very, very different, and we need to be in a position to ask the appropriate questions to distinguish and understand those differences. If we start first of all the fact that we're now dealing with a closed non-compliant circuit, we've got a very responsive hemodynamic balance that incorporates your systemic vascular resistance, your circulating volume, and your cardiac output or pump flow. And the parameters within this hemodynamic balance are intrinsically linked. You cannot change one of them without influencing another. And this is a different mindset when you move from conventional bypass. If we move through the system and start at the entry point to the miniature or all bypass systems with venous drainage, and what miniature bypass does is it offers controlled volume removal from the heart, essentially controlled negative pressure. And that's a benefit that's rarely discussed. And we need to understand venous drainage if we're going to actually understand the benefit that this control has. Now, our group looked at 60 patients, 20 in gravity, 20 vacuum, and 20 kinetic venous drainage. We kept the height difference between the right atrium and the entry point to our reservoir the same for all 60 patients. And we measured the negative pressure as close to the tip of the venous cannula as we could sensibly. What we found in the kinetic group was the venous collapse pressure was patient-specific. And we kind of already know that, but it gave us some figures. And it involves an interaction between the cannula, size and type, the patient, and the negative pressure. And it varied from negative 8 millimeters of mercury to negative 54 millimeters of mercury. You can see it highlighted there. Gravity venous drainage generates a pressure in the range of minus 26 to minus 48 millimeters of mercury. So you can see, even with gravity, we're providing suboptimal venous drainage, essentially sucking too hard, for patients with a collapse pressure in this region here. With vacuum assist venous drainage, we applied negative 35 millimeters of mercury to the reservoir, outlined as the maximum that you can do in the Shin paper in 2000. And this actually generated a pressure range between minus 56 and minus 79. So with vacuum, we're actually providing suboptimal venous drainage in all the patients that we measured collapse pressures for. So with that information on board, you can see how it's a benefit of miniature bypass to be able to control the volume removal from the heart, prevent venous drainage, and it essentially, if you know you're optimizing your venous drainage, you know then you're essentially removing another variable, and you can concentrate on the hemodynamic balance that I discussed earlier. Air removal and management, I might have a slightly different viewpoint than our first speaker, but he summed it up when he said it's a closed system. Air introduced on the venous side, quickly translated to the arterial side, quickly translated to the patient. And for us, for our group, we think there are three key things for an air removal device. It has to be 100% effective active air removal. That goes without saying. The volume removed with the air, which wasn't discussed in the first presentation, has to be made available to maintain the hemodynamic balance that I discussed earlier, especially if we're going to roll it out to a high-risk patient population. And the air removal cannot interfere with the artificial heart and lung support. That sounds very basic, but some of the systems in the market actually do that. This is the system that we use. We've got a bubble detector in the venous line, just before a side entry, 120 micron filter. This creates centrifugal force, which encourages air, as mentioned previously, to gather in the center of the filter. When the bubble detector detects air, it triggers a roller pump, and it removes the blood and air from the top of the filter. This blood is then made available to return back to the systemic system. Petherill's group, amongst many, he was mentioned earlier, but amongst many conclusions and positive benefits about miniature bypass in his 2000 paper, identified over an 80%, he was using this device, an 80% reduction of microemboli in the arterial line using this system over conventional bypass. So it's a very effective system. Here you can see it being used. There's your bubble alarm. You can see here the air's arriving in. You can see the centrifugal forces, and you can see the air being cleared. And that's without interfering. Here you can just see the RPMs in our centrifugal pump. So the device in the eyes of our group is extremely effective, and something that actually we'd be thinking about rolling out too if we were continuing on with conventional bypass. Okay, downstream we get to the gas exchange device. A miniature bypass is billed as offering a benefit in terms of reduction of blood-foreign surface contact. The largest surface area, or the largest non-physiological surface area in our system, is the oxygenator or gas exchange device. Now, our group's experience, we use a 1.8 metre squared oxygenator for most of our conventional bypass. In a warm patient, we rarely get a FiO2 above 55 to 65%. That's leaving us a 35% reserve. Some of our conventional population and our miniature bypass population receive a 1.1 metre squared oxygenator. And even in our biggest patient, we still only were using an FiO2 of 80%, suggesting that we still have a 20% reserve. So clearly, even at 1.1 metre squared, I kind of get the feeling that we're being over-efficient in this very non-physiological surface area. And if we put these numbers in perspective, because we brandish them around a lot, and it helps us understand what we're going to minimise. This is the surface area within a 1.8 metre squared oxygenator. And during your average case, 90-minute bypass, every drop of the patient's blood will pass over this 74 times. You compare that to your 1.1 metre squared oxygenator, and you can see how much room there is within this device to minimise that non-physiological surface. So, vent and suction management. Well, on this side of the slide, you can see well-managed suction or vent blood. No air, no blood-air mixing, no negative pressure. And this is done principally with communication, sucking pools of blood, good management by the perfusionist. On this side, you can see poorly managed venous blood. And with conventional bypass, this blood is actually disguised. It goes into your top of your venous reservoir, it's defoamed, it's filtered, only down to 40 microns. Don't let that fool you that all the microemboli you've generated has been removed. Whereas with miniature bypass, you actually see a consequence. You actually see it before you, or it triggers an alarm. And that moves me on to probably my most unscientific slide in my presentation. But one of the primary benefits of miniature bypass is that it promotes good practice. We mentioned earlier about air introduction to the system, whether it's through sample ports, fluid addition, or surgical air. The one thing we can be sure about from the very conclusive Wilcox paper in '99 is any air we introduce to our system that we don't get rid of effectively will directly translate to a microemboli delivery increase to the patient. With conventional bypass, there is no consequence to air introduction because your venous reservoir deals with that. With miniature bypass, there is a consequence. The technology makes you think about SVR and the hemodynamic balance and what exactly the patient needs. I've already mentioned it doesn't disguise poor vent management or suction blood, and it promotes multidisciplinary communication. Even for our conventional bypass now, we spend more time communicating with the surgeon and the perfusionist. And I really trawled the literature to find some sort of scientific backing for this, and all I could come up with was the Ramada paper in 2006, that one of their conclusions was that miniature bypass requires more careful cannulation. Surely all bypass requires careful cannulation. And if we tweak that slightly, careful cannulation, good practice, promotes. I'm kind of clutching at straws here, but you can see where I'm going with that. So, with all that information on board, we need to be able to define the miniature technology. The first thing we need to do is talk about prime volume. Now, over 100 cases at our unit, we managed to get the prime volume down to 134 mils, which is pretty impressive. But actually, now we're moving away from that thinking. Our group doesn't think that prime volume is actually that significant. You could probably go 200, 300 mils above that. I think it's the way the prime's delivered, and I'll come on to that in a minute. In terms of artificial surface areas, for the literature, we need to publish what our total artificial surface area is. And for our own groups within the hospitals, we need to understand the breakdown of various components within our system, so as we can accurately decide what to minimise, and I'll come on to clinical applicability in 1 minute. We need to describe what air interface is in our system and understand. Sometimes we'll use a MIDI-card, which introduces an air interface. It's an open reservoir. Air handling I've discussed, and like all bypass, safety features are critical and need to be described. If we're moving on to defining the management of the technology, well, the patient-prime interaction that I just touched on is absolutely key. Perhaps not so much the volume. Here you can see a retrograde and an antegrade prime. And when we started off, we felt that this particular process of displacing our prime with the patient's blood was about reducing prime volume. But I don't think it is. I think it's about extracorporeal blood prime mixing. And you can see the evidence for that. Maybe. Yeah. In this particular slide, we've got time on bypass along the bottom, and we've got hematocrit up this, on the y-axis. This is for the first 400 seconds of bypass. With conventional bypass in blue, you can see as we go on bypass, we drop to a hematocrit of 12%. That's why your patient's head blanches as you go on bypass. It then takes 4 passes to stabilize before you get a stable hematocrit. With miniature bypass, the red line, the hematocrit only drops to about 26%. Your patient, if you're a mini bypass user, you'll notice their head will stay pink. This is principally because the bulk of the blood prime mixing is done outside the body. And then you get a far quicker stabilization in the hematocrit. In terms of hematocrit management and circulating volume management, these two things go hand in hand. If you focus, like many centres did in the early stages, including ourselves, solely on the maintenance of hematocrit, you become volume restrictive. You're getting the balance and the management of the technology wrong. And the thing that was very hard for us to learn is that some patients are going to end up with a low hematocrit. It does not mean that there's been a failure in the technology, because we've got the other benefits that I've described earlier. This is an example. Again, we've got a bypass time along the bottom and the volume added up the side. The red line is miniature bypass, the blue line is conventional, and you can see both these patients received 2.5 litres from the perfusion side during the operation. Now, if you'd have told me when I started off miniature bypass that I'd be giving a patient 2.5 litres, I'd have said we don't want to look at your technology. But the difference, again, is the way the volume is managed. With miniature bypass, it's in large amounts. Localized hemodilution, localized oncotic destabilization. With miniature bypass, there's little aliquots of volume throughout the case. It's a far more gradual approach. And really the reason for that is exampled here. What you'll see is the perfusion flow, the cardiac output, and the venous line pressure. As the venous line pressure becomes more negative, it's suggesting your patient is empty, your circulating volume is low, and as I mentioned in the hemodynamic balance, your other parameters will change. You'll see the perfusion flow drop down. The perfusionist will then add 20 mils or so of volume, which is a very small amount, and this stabilizes the hemodynamic balance. So there you see the flow being affected. The volume's being added. We use a soft shell bag, and you can see that the hemodynamic balance has been restored. All the other bits and pieces here are critical, and again need to be defined if we're going to define our systems properly. How we add drugs, air-free you would hope, how we manage our SVR, what our targets are, and how we manage suction and suction and vent blood. Because, as I said earlier, there's a lot of user variation from hospital to hospital. We cannot presume what we do is the same as what other centres do. So what's the overall objective of miniature bypass? Well, you're trying to achieve better bypass without negatively influencing safety, the technique, the time spent, and the effort required to perform the operation. And we need to think about the system selection in terms of functionality. It has to be a system that fits into your hospital environment, and protocols that fit into your hospital at standard practice. You've got to make the decision and understand what exactly your centre wants to minimise. I mean, I use the example of tubing versus oxygenator. You know, to achieve the same reduction in non-physiological surface area that I showed you in the previous slide, between 1.8 and 1.1 metres squared, you'd need to remove 42 metres of 3/8 inch tubing. So really, there's no point in shortening tubing and then using an over-efficient oxygenator. Bringing yourself too close to the operating field without actually getting some tangible benefit doesn't necessarily suggest you've got the balance right. And then probably the most important bit, and some people would classify this as dumbing down the technology, but it's not. It's understanding the system and understanding when to compromise in order to achieve clinical applicability and an overall benefit in a larger patient population. So for us, for example, We use a soft shell reservoir, unlike the previous presentation. Okay? We can then extend. Now, this soft shell reservoir, of course, increases our surface area, our non-physiological surface area, but not significantly in comparison to our oxygenator. And yet, it allows us to roll this technology, as you'll see from the next operation, out into AVRs, many other more complex operations. As I said earlier, for some operations, we actually use a MIDI card, which increases your surface area and adds an air interface. But this allows us to do aortic root replacements, emergency dissections, minimally invasive mitrals. So it's understanding when to compromise the technology in order to get clinical applicability. So in conclusion, miniature bypass isn't just about reducing hemodilution. There are many other benefits. And the ideal system actually requires an understanding from the cardiac team that allows them to balance appropriate hospital-specific advantages with clinical applicability. The ideal miniature system includes the high-risk patient population. It's going to have to if we're going to see the benefits in the literature. And if cardiac teams are able to do this and design the research accordingly, then miniature cardiopulmonary bypass has a very bright future. Thank you.
Thank you, Dr. Mulholland, for this accurate presentation of all technical issues and mini bypass systems. For the sake of time, Christoph, we should proceed with the next presentation. I think Dr. Mulholland will be so kind as to postpone answering a question in the lunch break.
Yeah, that's no problems at all.
Yeah.
Anyone who has any questions, feel free to come and see me.
Okay. Thank you very much for your understanding.